thank you all for being here. We're just really, really thrilled to have each of you. So I guess it would be great to start off with kind of hearing from you about your sort of journey to working with n-Lorem and sort of what do you feel are the important things that we bring and that we need to make sure that we maintain in our relationship with working with you. And Sesh, if we might start with you.
Yeah, thanks, Sarah. Well, first, I'd like to thank Stan for his vision and leadership. And I'd also like to acknowledge and thank both Dr. Stan and Dr. Roseanne Crook for putting the wind in the sails of the n-Lorem initiative. So I think that's been terrific for all of us and especially for our patients. So as a baby doctor, I get to take care of children and families who don't get to choose me. They have to sort of accept that I'm on call that night. And consequently, I have to earn their trust. And that earning process has, for me, really informed how I then manage and help them manage their hope. Because they then rely on me, as do the UDN participants who get diagnosed rely on those of us who participate in their diagnostic odyssey. They rely on me and us to help them hope. And so in order for me to respect that hope, I need to be able to trust the processes, opportunities that I refer the patients to. And n-Lorem is, for me, the sort of benchmark of trust. n-Lorem has taken extraordinary measures to be sure that when a patient is referred, that patient receives absolutely transparent, rigorous, and informed by experience consideration. And I know that if the answer is yes, n-Lorem will take that patient will get extraordinary care and treatment from n-Lorem. But I also know that if n-Lorem decides that for whatever reason, because of the biology of the variant, because of the progression of the disease, or for other reasons that patient is not a candidate for an ASO developed by n-Lorem, that I can trust that opinion and work with that patient and family to move on to the next source of hope. So I think trust for me is a big deal for n-Lorem.
Yeah, thank you, Sesh. Liz, what about you?
So I want to thank Stan also for developing this program and all the people who work for the program because we've had great relationships with them. But I think when I went into neurology a long time ago, I went into neurology because I felt like it was a completely open field where we didn't have really any treatments and any treatments targeted to the diseases that we actually treat. And I thought, well, there's going to be research and I'm going to be there for the happening of those treatments. So I thought that was going to happen about 20 years ago, but now, after 30 years, it's actually happening. So this is extremely exciting. And over the years, I've kind of gotten to be known as the rare genetic disease doctor of neurology patients in Chicago. And so I get self-referred patients, and so my patients do often choose me, but unlike Sesh. But you know, doctors choose to send the patients to me. And I look at this and okay, there's a gene mutation and it's in a gene that I've never seen a patient before because that's getting really common these days. And I immediately go and dig into the internet and papers and everywhere and try to find out what does the protein do, what does the gene do, what's the mutation doing to the gene. And then I meet with the family and try to figure out how big of an impact is this disease having on the family. And then I ask some questions. Are there trials for this disease? Often not, because there's only 50 patients in the world. Or is there a foundation? Sometimes there's a small foundation that a family has created online. What work is going on the disease? And then I ask, is this a mutation that could be targeted by an ASO? Because that really has been like one of my frontline questions when I see a patient in the past couple of years. And then one can go through a process of thinking through the types of mutations and even submitting to n-Lorem, which I have also done. And then even in the back of my mind, if I'm thinking, ooh, this is an intronic mutation, maybe it would be targetable by an ASO, I'm thinking, what is the disease concept model for this disease? What are the things that are impacting the family most about this disease? What would I want to try to improve on, and how would I measure that? And I think those are the things that go through your head as you see these patients. And the fact that we even have the opportunity to do that is frankly amazing. So really every rare disease patient I'm looking at, I'm thinking, what could we actually do to treat this person's underlying biology? And I think by doing that, we have the opportunity in this generation to understand basic concepts like what can we actually reverse if we treat patients after birth, when they have neurological diseases. How much havoc has already been wreaked on the brain by the time you get to the patient at 5, at 6, at 30. Those are concepts that we need to learn, and we're only going to learn that by collecting all the information, sharing the information, working together, and then that will circle back and help us understand the clinical responses to these drugs is going to help us understand the disease mechanisms somewhat, even the basic science disease mechanisms somewhat better, and it's going to help us understand how to do the whole process better and what measures can work to measure changes in what patients. And just being a part of that process is extremely exciting, and n-Lorem has certainly facilitated that.
That's awesome. Thanks, Liz. Olivia, what about you?
I mean, for me, as my perspective from a pediatric epileptologist, I mean, you can see the amazing families that were up here this morning. That's very representative of my clinic. It's different variants, but often manifesting with similar symptoms, which are very intractable and severe at onset. And so the fact that there is even a potential for targeted treatment, this is very important because it's not just about seizures and brain, but it affects the whole body and a genetic mutation. And so the opportunity to even provide patients with a targeted therapy, this is so important to even put out there that it's a possibility, and then that will also continue to drive earlier genetic diagnosis and intervention. This is very important and will change, I think, landscape of neurologic potential, as Liz mentioned already. And so this is why I'm working with n-Lorem and the amazing team that they have.
That's awesome. Neil, what about yourself?
Well, I think my relationship to n-Lorem is a little bit different than a lot of panelists and other doctors that work with this wonderful group. I'm an ALS guy. I don't work on many diseases. I work on a disease. ALS is a devastating disorder still, and despite a lot of great work from a lot of people around the world over 80 plus years since Lou Gehrig had this disease, we still have very little to offer our patients, except those rare patients who have genetic mutations, whom I think we can now offer a gene-based therapy that is attacking the most proximal mechanisms in the development and genesis of the disease. I said I came to this out of my experience with FUS ALS, and I can say I've been doing this for 25 years. It's the single most satisfying thing I've done is the work I've done with JC and Anna, Ionis and n-Lorem. I just see the potential to do more of this for more patients with even more rare mutations than the FUS mutations. And n-Lorem provides, for the reasons you've heard today, a platform to do it. Wonderful people that you've seen on stage, that are trying to enact Stan's vision for this. You heard the words hope, rigor. And dedication. This is what we offer patients with, I think, a potential to help lots of people. And even though I'm a single disease guy, I think that the things that we're doing through Silence ALS and for ALS patients and families have large implications for other diseases as we hone our processes and our approach to these cases.
Awesome, thanks, Neil. So I just wanted to have a couple questions about kind of the patient identification and sort of movement into n-Lorem, determining whether we can help these patients or not. And Sesh, maybe we could start with you. I know you spoke about your leadership in the UDN and what an important element that is to potentially be able to then, the therapeutic matching committee that you lead. And I was just wondering if you could share a little bit with this group is about the considerations from even a technical or a functional genetics perspective that you're putting in your mind, and also as a member of the ATTC. So when you're thinking about these recommendations, this is such an important decision, and it's the gravity of the decision we fully acknowledge is significant for different patients. I wonder if you could speak a little bit to that.
Yes, well, the Undiagnosed Diseases Network does focus on genomic diagnosis, but then functional confirmation and mechanistic confirmation of what is encoded by the specific variant that the patient carries. And so the UDN participants have an unusual leverage in that we understand something about how the misspelling in the gene disrupts the patient's body. And so that knowledge is critical as we think about who would be best served by which kind of therapeutic intervention. And having that kind of understanding really helps the Undiagnosed Diseases Network cooperate in a very open and transparent way with n-Lorem. In addition, the UDN does very deep clinical phenotyping. So we know what current status of each UDN participant is from a biomarker standpoint, from an imaging standpoint, from an operational standpoint for activities of daily living. And so we can share with n-Lorem what at least our opinion is about what amount of that phenotype is reversible and what amount of that phenotype is not going to be reversible. And that's so important in informing the thoughts about who is really going to benefit most from an ASO. It also is critically important to share with family members or the patient to be sure that they all understand that given this phenotype, this is at least one, this is what we can expect might be reversed by the ASO treatment.
Yeah, and that's a really, I think the point about the depth of the understanding that the UDN gains on these mutations is really important, because not all patients are being diagnosed through UDN, of course. And we know many of the patients that actually apply to n-Lorem may have a mutation that has some knowledge around the functional consequence, but if it's not sufficient information and sufficient research on that consequence, our team, we are not able to identify and feel confident in an ASO strategy. And that's definitely a component, that sort of proof of concept element, is how can we support, even from the diagnosis to really and truly having an understanding of the functional consequence, so that then our team can get to work on what the ASO strategy might be. Olivia, I wonder if we could turn to you and just, love to get your perspective as kind of you continue to grow your practice at Rady, and thinking about the patients that you would nominate for treatment with n-Lorem. From a clinical perspective, what are some of the things that you're thinking about or that you're looking for that, even building on what Liz said, is how you're thinking at the very beginning about how you would be able to assess the benefit of a treatment or not?
Mm-hmm. I mean, of course, the basis is going to be the genetic testing is going to be the main thing first. And then in terms of clinical symptoms, what is most bothersome to the patient? Also, what is the disease-specific clinical symptoms that we can potentially follow along a treatment regimen or a clinical trial and assess for change or interventional effect is very important to really streamline, because everybody is different. Every variant is, as much variability as there is with genetic variants, there is with phenotype as well. And so it really has to be tailored to each individual. And also, it's not an easy process to even consider doing an ASO trial in your child. It's a big decision as well. And so that comes into play. And so those are some of the main features that really have to be addressed.
Yeah, thank you. That's very helpful. So I wanted to, in the next couple of questions, talk to Liz and Neil. So both of you have been treating patients with the ASOs, and just speaking to your experience, you know, in Liz, really thinking again, wanted to come back to the fact that you are the expert here on many of these outcomes, and I think this closet concept, that's so cool. We continue to hear about that, and from a neurodevelopmental perspective, and just really thinking about, from your perspective, what are some of the key kind of challenges that you have had, or things that you've been thinking about in the context of continuing to make your treatment decision, as far as understanding the benefit risk and whether this ASO seems to be helping a patient?
Well, you know, there's a whole list of things that goes into consideration. Obviously, you know, we can diagnose a patient with a super rare disease that's a degenerative disorder, but if they really have limited function left, then there may be no way for us to actually stop the disease, even if we had something that worked. So that's a consideration. A consideration is whether the family is ready to take a jump into experimental treatments. And, you know, then the consideration is, do they have something that we can actually target? And in terms of trying to get the whole thing together, if we decide we can treat a patient, there's really, these patients come from all over, and they often have clinical information here and there, and so you really have to try to gather. We've been fortunate with the patient that we've treated. We got all of his information from Boston very nicely. We've been able to coordinate with a neurologist in Florida for things like EEGs. We do have to coordinate our institution, actually, and we have a process that we developed for that, actually, through our Angelman syndrome work, where we, you know, even when we admit patients who are getting ASOs after their first doses overnight, we have a whole system with the nursing services there, and, you know, you have multiple professionals that do things that just kind of do work on our trials, like nerve conductions and MRI, and so there are really many things to consider and coordinate in an individual hospital. It is quite an undertaking, but worth it.
Worth it. Yeah, and Neil, I mean, that's exactly, I feel like, a lot of your experience as well. I mean, of course, patients come from all over to see you at Columbia, and I wonder if you could just comment, you know, a little bit on how you envision that working from a coordinated care perspective and data collection, and even patients who are at other sites outside of New York City, perhaps, or even outside of the US, but still want to get this treatment and perhaps have the dose administered by you.
Yeah, so again, a lot of what we're doing with n-Lorem for silent ALS is informed by or based on our experience with the FUS ASO, where, you know, which began as an N of 1, and then 2, and then 5, and then 10. And, you know, I think this is going to be the experience of a lot of people, and then people come to you from, you know, many parts of the country and different countries, and you have to, you know, figure out a way of adapting your process, you know, to accommodate these people. And this is what we're, you know, doing and going to have to do more of with n-Lorem. You know, I think that it's hard to standardize, because institutions are so different, and you know, local specifics are different, but we're trying through silence, and I think n-Lorem more generally, to standardize these things in a way that would make it, you know, easier to involve other patients, other genes, other, you know, mutations, and I think that's coming. You know, and I just also, I think, wanted to say in terms of processes that, you know, and Stan said it this morning, that these are human experiments, right? So you're dealing with a lot of uncertainty, and, you know, you can be as careful as you want to be with, you know, in advance of delivering an ASO, with phenotyping and trying to predict phenotypes and endpoints, and, you know, but you have to be prepared to accept the unexpected. Stan presented the case of Anna today. You know, Anna bottomed out. You know, we thought that she was dying, and then began this absolutely remarkable, unprecedented functional recovery. At a time when, you know, people had given up on her, she hadn't given up, and her family hadn't given up. So, you know, we're learning what success looks like in these diseases where there's never been success. We're learning to, how to deal with patients at the time of nomination through the period of ASO development and delivery, and then through the treatment period. So these are very early days, I think, and I just think we have a lot to learn.
We do have a lot to learn. And, I think even the standardization, I mean, the red cap that Lori spoke about earlier, in theory, the idea would be that the same red cap CRFs could be leveraged for any physician. So, for example, if Liz's patient is being seen in Florida and, all these other places, then anybody who sees that physician, the idea would potentially be to standardize in that way. But there are many, many other ways, and the standardization is so critical. So we only have a couple minutes left, and I was going to ask a question about funding and then a question about challenges, but I imagine those two things might go together. So I wonder if I could just turn to each of you and sort of in the way that we're going to be working together in the future. Obviously we have a number of ideas for strategic solutions to help you all, to help the physicians that are in the diagnosis and in the treatment space, and institutions that we want to try to work on together. And Stan will talk about some of those others later today. But I wonder if each of you could kind of just comment a little bit on kind of what are the key challenges that you hope that we can tackle together here in the short term. Liz, we'll start with you.
Okay, so the institutions are not a small barrier. You basically have to really push your institution into doing this because they don't want to, because they think it's going to cost them money. So if you can convince them it's not going to cost them money, then sometimes you can go forward, and that's basically what I've had to do. And then, so I've had a few kind of novel solutions to some of it. We've recently actually created an N of 1 fund in philanthropy to work on finding donors that want to give money to Rush to potentially support this exciting treatment of individual patients with personalized medicine. So that's one of the solutions we've had to the institutional issues. I think one of our big challenges in the field, of course, because I'm in neurology, is outcome measures, which is a challenge for everybody in neurology. And I think that I was the originator of the closet idea. And I think what we need is to add all this work together, share it among other groups like N1C and like Combined Brain, which wants to do outcome measure standardization as well, and get outcome measures for each type of thing like cognitive or motor function, and for each severity, because you would use different measures for someone mild, moderate, or severe, validate those, get those, sort of that you have them on the shelf, and people can come in, well, I have a patient like this, and so these are things that I could potentially consider using.
Yeah, that's great. And Liz has been I think you've been a great mentor also for other physicians have often learned a lot from your experience. Sesh, what about you?
So, not being a neurologist, because I wasn't smart enough. I wasn't smart enough to be a neurologist. I take care of babies, and the biggest problem for babies is breathing. And misspelling in rare misspellings in various genes disrupt the lung transition from womb to world. And some of these rare misspellings result in irreversible and progressive lung failure, which currently is only addressable with lung transplantation. So we transplant half dozen babies a year with these genetic misspellings for whom nothing else is available. And I am hopeful, thanks to Stan's support, that we are going to make some progress on ASO development for helping these babies to breathe without transplanting their lungs.
That's amazing. Yeah, thank you for that. Olivia?
I think, in terms of challenges, there's very many bringing an ASO forward in an institution. I mean, funding, regulatory, lots of different aspects that need to move in parallel to really deliver it at the same time. And that's why the funding mechanisms, like Liz said, with philanthropy is very important, outside of grants and things like that as well. And then the institutional buy-in, I mean, it's a different model from regular clinical trials, even if it was for rare disease clinical trials. And so that takes a lot of effort, and then explaining that and then changing the regulatory model and even IRB processes. And so that takes time. I think it's going to be an issue across all institutions, and that's why it's important to partner with other groups like N1C or n-Lorem in bringing these things together so that we reduce redundancy and effort and just kind of streamline things for everybody to move things forward.
Well, the first time will always be the hardest, right? So it will never be this hard again for you. Let's hope, right? Neil, how about you?
Well, I mean, I think many of the challenges have been mentioned. I would say one of the greatest areas of challenge is going to come from our success. That as these things start working, I think we're going to be seeing more and more cases, and dealing with that volume is going to be tricky. In the case of neurodegenerative diseases, and this may be a little bit different from some of the developmental disorders, we have the ability to identify and track individuals in advance of symptom onset, and I think that we will have challenges related to the implementation of these therapeutics earlier in patients' course, and ideally even before disease onset, and dealing with the regulatory and logistical challenges of that, I think, is a happy challenge.
Yeah. Well, that's a great way to end the conversation. And just thank you so much. I'd like to thank all our panelists for being here today. Appreciate you guys.